We will be talking about programmatic adaptations that occurred during the COVID-19 pandemic and what we learned from those adaptations. So before we dive in, I did want to start with a quick Slido poll to try to keep things a little interactive. So as they pull that up, you can join the Slido with that number or point your camera to the screen and to the QR code. And is this, ask my tech people, is this our Slido? Yes, I think so. Okay. Do you want me to toggle?
So we start with the Slido?
Yeah,
Okay.
sorry. I should have told you that.
This one, scan this one.
Yes, perfect. So the first question is, what comes to mind when you think of program adaptations during COVID? So if you can put in 1 or 2 words, and you can answer multiple times if you'd like. I see self-care and digital coming up. Give you all a few minutes to get into it. I know it takes a little time sometimes. I know there's more than one person in here. All right, digital also, okay, and telemedicine, great. Okay, so lots of digital types of adaptations is, I think, what comes forefront in our minds. Oh, one more person is typing, so we'll wait till they come in. And task sharing, very good. That's a very good one since we made use of a lot of community health worker interventions to get to that last mile. Wonderful, so we'll go ahead and get started then. We'll go back to the slide deck, sorry. It's okay. So while they get the slides up, you know, there's no surprise that there were a lot of COVID-related sessions during the conference today. Some of them were focused on the COVID impact on family planning use. Some were focused on advocacy efforts to ensure continuity of family planning services during COVID. And our session today is a little bit different than that. In our session, we have 2 goals. The first one is to showcase some program adaptations that did occur during the COVID-19 pandemic that helped to ensure continuity of services. And these were really innovative adaptations that helped ensure that people could still access family planning during the pandemic. And we'd like to focus on these positive stories to share an overall message of hope and resilience with our family planning programs. But perhaps what sets this panel apart from other sessions is that our goal with this session is to showcase also different ways that we've documented our program adaptations. So we've heard from family planning professionals around the world time and again that we have a lot of evidence and best practices, but we don't have a lot of details on the how of program implementation, and in the case of COVID, of adaptations. So it's really important that we document our implementation approaches in a lot of detail, provide information about context so that we can understand, you know, how easy it is to apply those adaptations in other settings. And so in this panel, we'll be sharing different approaches that we've used, that the panelists have used, to document those adaptations during the COVID pandemic. So without further ado, I'd like to introduce our first panelist, Nandita Tate, a technical officer with the WHO IBP network. And Nandita will be sharing some of the knowledge exchange and documentation activities undertaken between WHO and the family planning implementing partners. So Nandita?
Thank you. Hi, everyone. Just to echo Rueda, we made it. We're the last session of the conference, so hope we can bring that energy for one more session. Very happy to be here. And as Rueda said, my name is Nandita Tate. I'm with WHO, based in Geneva, Switzerland. As part of my role there, I lead the IBP network, which is a network of NGO and civil society organizations. And we leverage that network to disseminate WHO guidelines, research, other evidence-based practices to our partners, but also importantly, use that network to hear back from partners, from the NGOs, from the civil society. What could WHO be doing better? What are the research gaps? What guidelines are actually needed? And so today, as Rueda mentioned, I'm going to talk a little bit about how that relationship really helped us not only understand program adaptations in family planning, but also better document them for use, both at WHO, but also among our partners. So, oops.
I'll just go to the next one.
Yeah, okay. I just want to thank my colleagues, James Chiari, who's the unit head at WHO in contraception and fertility care, Carolyn Ekman, and Ados May, who are also part of the IBP network, for their support. And of course, all of our partners who contributed to this work. So let's go back in time. I know COVID feels like a little bit of a bubble, and it almost at this conference feels like we're reliving that bubble. We started off with no masks, everyone hugging, kissing, and now everyone's masked up. And anyways, but just a reminder where we were back in 2020. March 11th, the WHO announced COVID-19 as a global pandemic. And pretty soon after that, WHO issued guidelines and guidance for maintaining health services. And this was really important because if you remember the scenes from China, from from Italy, from New York, and then pretty soon around the world, there was quite a lot of confusion on what do we do? How do we maintain health services during this pandemic? And things moved quickly and are still moving. In fact, as of today, or rather when I made these slides a few weeks ago, we've had 625 million people infected with COVID-19 and 6.5 million deaths. So it's still here with us, and it was really important to get this global guidance out quickly. Pretty soon after that, we issued guidance specifically on contraception, and that was a result of hearing from some of our partners that we need to know what to advise partners in terms of providing contraceptive services. And then we started the task team, and I'll get to that in a minute. So before we continue, I think many of you saw WHO in the limelight for the first time in a while during the COVID pandemic. And I'd like to get a sense, what do you think the role of WHO is during a pandemic? Okay, how do I go to Slido? Sorry. Hold on.
Get out of presenter.
Okay, sorry.
And then oh, okay. I don't know.
Yeah. Okay, so we'll go to the
Advance the
next
next
poll. Okay, sorry, one sec, yeah. Okay. Oh, no. This is the previous one. Hold on, don't do that one. Okay. So I'd like to just get a sense. We've seen WHO in the news after COVID. What do you perceive as the role of WHO during a pandemic? And you can select multiple. Okay. So we've got global guidance, combat misinformation, share data, mobilize partners. Okay, there we go. Now we've got some variety. More people answering. Good. Okay. So we can see it's quite a range of activities that people look to WHO for during a pandemic or during any health crisis. Global guidance, mobilizing partners, combating misinformation. And so we're going to touch on a few of those today during my session. Okay. So now let me just go. Okay, here we go. Okay. So as I mentioned, thinking about WHO at a global level, we issued guidance, we developed the contraception fact sheet, and we provided regular and clear, transparent communication. One thing I want to note, part of our work through IBP was important because as we developed some of this global guidance, especially the contraceptive fact sheet, that was really came from the ground. So we were hearing from our partners, we really need information specifically on contraception. And so we were able to put this together, we were able to translate it, put it in an easy to understand format. So we used a FAQ, frequently asked question format, rather than the typical 200-page guideline document. And that was really critical as well. And the other big piece was this regular and clear and transparent communication. And I think WHO did a really good job of that at a global level. How many of you attended the press conferences every day? Okay, really? Only one person? That's fine. Not every day. But you can see that that was the first time WHO was really visible, really trying to provide that information on a global scale to everyone. And that was really important because what we saw was a lot of misinformation. And I think you've heard about the term an infodemic. There was a lot of myths, misconceptions, misinformation around COVID. For those of us working in the family planning field, this is actually not new to us because we deal with a lot of those issues all the time. And so there was a lot that our partners were able to share in terms of how to address some of the misinformation given their experience in family planning programming. So I'm going to go to one more Slido. I know this is a little complicated. Hold on. Oops. Okay. So we did one more just to get a sense, kind of what we were hearing. So which of the following, sorry, which of the following were documented rumors about COVID-19? Okay, so we'll give you a few minutes.
Is that the right one?
No, it's the wrong question.
Oh, I'm sorry. I didn't even touch this thing. Okay, not touching it. Okay, here we go. Which of the following are, oh, see, look, it's doing it on its own. I don't know why it's doing that.
We could just yell it out.
Yeah. What do you think, people? I'm sorry, I'm not sure why it's doing that.
I think you have to click stop.
Sorry.
So what questions are we on?
No, this
Three?
one.
Okay.
Yeah. Okay.
Yeah,
Anyway, what do people think?
you could raise hands.
Oranges? COVID-19 comes from oranges?
Bleach.
Drinking bleach, cow urine. That's pretty creative and kind of gross. Mobile phones. And so the point here is actually all of these were documented rumors. So there was evidence that showed that people really did believe all of these rumors about COVID-19. Here we go. And I show that just to highlight that this idea of misinformation was quite prevalent in COVID-19, it's prevalent in family planning, and it's something that WHO really tried to address during the pandemic. And some of the work that we did through the task team was aimed at providing that clear and consistent communication. Okay, back. Okay, there's no more Slido, guys, so it'll be smooth sailing from here. So that was WHO at a global level. And what we learned quickly was that in addition to the global guidance, there was a lot of demand for specific guidance related to family planning or sexual reproductive health. And so that's where the work that we did through IBP, through our partners, came into play. And so I want to just touch on 3 activities that we undertook to help address this issue of information, communication, and dissemination of guidance to our partners, specifically around family planning. We convened a task team, we hosted global and regional webinars, and then we produced an adaptations map. So I'm going to talk about all 3 of these. So the task team was convened pretty quickly after the announcement of the pandemic. Oops. We had over 105 individuals from around the world join the task team, and it's actually since grown. And it was really an opportunity to sort of convene, share knowledge about what were the challenges programming, what were some of the solutions. And that task team is actually still relatively active. It's active on the WHO IBP network site, and we were able to sort of maintain sharing experiences by email. I think in total we had about maybe 15 to 20 meetings sort of throughout the first 2 years of the pandemic. And it really provided that space for partners to exchange information and hear from WHO on what the recommendations were. We also hosted a number of webinars, and I think all of us sort of got pretty savvy with Zoom during the pandemic. We actually were quite familiar with webinars, having run many of them previously. But these were really important because they were an opportunity to provide, again, that guidance from WHO directly to partners, but also hear from partners about, what the challenges were on the ground. And we were able to have those in English, French, Spanish, Portuguese to really highlight regional and country variations. And then the last activity was the program adaptations map. And again, this was solicited from partners to document what adaptations were you doing on the ground. So it was an open source activity. It was easy to input information. We sort of reached out to our network of 20,000 SRHR professionals, and we organized adaptations along service delivery, social behavior change, and enabling environment. And then we provided contact information, so people were able to communicate with each other. If they saw an interesting adaptation in Zimbabwe, they were able to connect and get more information to perhaps replicate in another country. So just to give you some idea of some of the adaptations that we saw from the map, you can see some of them here. Some of them were around sort of actual service delivery. So we saw this organization, for example, start to provide multiple pill packs for contraception to its clients. So previously, there was a lot of restriction, and it was like you had to come back every month to get a pill pack. Because of the pandemic, they were able to provide multiple pill packs. We also saw changes in the way education activities were conducted. So this organization in Mali modified large community health fairs to smaller education sessions about distancing and hygiene. And finally, we saw another service delivery example here is leveraging an existing service through mobile clinics to provide family planning services. So this is something that this organization wasn't doing previously, but they were able, seeing that there was a gap in service delivery, they were able to provide services. That map was really popular, and so it was actually replicated and sort of worked together, the family planning map and a map here on safe abortion response. Both are still active, and they're still open to input adaptations. So if you have adaptations for both outcomes, you're welcome to input them. So really quickly, just lessons learned. Global platforms can amplify local experience, and I think that's really the take-home message here is when you have a sustainable platform like something housed at WHO, you can really amplify local experiences. And we saw a lot of the adaptations were from local organizations, and that learning was taken back to WHO, which really helped strengthen the way we provided future guidance. And also local experience is critical to informing the global evidence base. So some of these adaptations might not be documented in peer-reviewed journal articles, but they're clearly effective, and so we're able to use that to inform future WHO research and guidelines. And finally, linkages to WHO are valuable, real-time updates. I mentioned the FAQs on contraception. All of these were opportunities that were strengthened by linkages between local partners and WHO. And finally, having a sustainable platform. What we see is that providing platforms through WHO that are sustainable allow for exchanges like this to continue beyond the life of any one project or one funding cycle. And so that was certainly a lesson learned for future outbreaks. So I will leave this here thinking about the future because I think I've run out of time. But just to highlight, I think it's important to have that quick mobilization, open, free, and sustainable platforms, and really, of course, recognizing the limitations and the ability to be agile and adapt is critical. So thank you.
Fine. Ooh, careful. Lots of stuff around here. Thank you, Nandita, for that. I actually remember very clearly attending several of the IBP task force meetings in the early stages of the pandemic, and I really appreciated having that opportunity to hear from stakeholders on the ground in different countries. I remember there were countries represented from Africa and from Asia and others, so it was nice to be able to hear what was happening in their countries and how they were adapting to the environment and the COVID pandemic. So I think, WHO, IBP really does play a critical role in bringing the global voices with country voices and amplifying those, as you said. So next I'd like to introduce Ann Ballard-Serra. Ann is a senior program officer with the Johns Hopkins Center for Communication Programs, and Ann will be sharing qualitative research findings on policy, program, and management adaptations from USAID funded projects specifically. And this research was conducted by the Knowledge Success Project. So, Ann?
slide deck up here first. Is it loaded onto the, here we go. Okay. Well, I don't have Slido, so for my interactive portion, I want to do some movement, I think. So if you guys want to just stomp your feet like this. Do it. All of you guys in. Let's make the room next door jealous. All right. Thank you. How does that feel? Energized a little bit. I know it's like lunchtime for a few of us in other countries. So I'm Ann Ballard-Sarah. I'm a Senior Program Officer at Knowledge Success with the Johns Hopkins Center for Communication Programs. We're a USAID-funded program that supports knowledge management for family planning and reproductive health professionals. Can you raise your hand? Did COVID cause like an unprecedented shift in everything that you do in your personal and professional life? Okay, I see most hands up. Well, no surprise, it did that for family planning and reproductive health professionals around the world, as well as us. And they were meant to adapt their family planning programs super quickly on the fly to make sure that women, men, girls could still access the essential services that they needed and that they wanted. And so we, as a knowledge management project, knew that it was really important that we would document those adaptations that were taking place. So, first, I want to recognize the co-authors on this work. There are several from the Knowledge Success team and several from the USAID Office of Population and Reproductive Health that worked with us on this research. So since we wanted to document these adaptations, these were our 3 objectives of this work: to identify and document policy, program, and management adaptations specific to USAID family planning and reproductive health programs during COVID, explore the impact of adaptations on their goals, and then outline recommendations for future work. And we did this work in collaboration with and on behalf of USAID's Office of Population and Reproductive Health. And a quick summary of our methods: this was purely qualitative research. We did 5 focus group discussions, 5 in-depth interviews, a total of 18 participants across 10 different countries. And we interviewed or did focus groups with staff from USAID Washington, USAID missions around the world, and then USAID-funded implementing partners. So since the findings were purely qualitative, I'm not going to quantify them and say how many implementing partners said X, Y, or Z. I'm going to say many, most, a few, or several throughout the response, throughout my presentation. And the findings are grouped by recurring themes, so based on how often we heard a topic mentioned during the focus groups or in-depth interviews. So first, we started the in-depth interviews or focus group discussions asking people, what challenges did COVID-19 pose for you and your work? And it was completely open-ended. They could say whatever they wanted. The biggest challenge that people experienced was a shift in priorities from family planning reproductive health to COVID-19. So people were struggling to keep family planning reproductive health on the agenda, on topic, to get the word out that family planning services still were essential services that needed to be provided. The second most common thing that people mentioned was the mental toll that it took not only on them, but on their teams. Several people that we interviewed mentioned that their team members had passed away. Their families were suffering with COVID. They had to take care of their children who weren't able to go to school. So it was just a really difficult, was and is a really difficult time for people. The third was travel restrictions. We specifically heard this from USAID Washington participants, that they felt as though the travel restrictions, that they weren't able to travel and like monitor programs, impacted their ability to kind of do the job that they had hoped that they could do. The fourth was client access to family planning reproductive health services. There were a lot of concerns that were validated that people were scared to go to seek health services because of the fear of getting COVID, or health workers themselves were getting COVID, and therefore there was a lack of services. And then finally, we also heard that while telehealth and digital approaches were certainly one of the adaptations we documented, they also really posed a challenge. People weren't used to that type of work. There was, it took a bit of time to get used to that. Were these challenges that you all faced or have heard of? Okay, I see some heads shaking. All right. But on the flip side of that, we also wanted to start the interviews by asking people what unexpected opportunities came from COVID-19 that we should document. And I thought that these responses were really interesting. So several participants mentioned that the fact that that people weren't traveling and there wasn't like in-person oversight from external teams led to more local ownership and leadership opportunities for people who may not have had that opportunity otherwise. So that was a great unexpected opportunity. The next was flexibility, creativity, equity, and collaboration. So, flexibility was the word that we were all using during COVID because we had to. So that was definitely an unexpected opportunity. And then there were also secondary outcomes. So a lot of programs, saw that there were raising rates of teenage pregnancy because people were out of school and all of that. So there was increased recognition for the importance of working on different topics, such as gender-based violence, teenage pregnancy, self-care, for example. So those were some unexpected opportunities as well. And then there were also opportunities for the private sector involvement. So what were some of the adaptations that we documented? We specifically asked about adaptations to country family planning reproductive health programs and policies that were implemented regarding the management or the implementation of programs. And in regards to family planning policy adaptations, we found that many participants talked about changes to specific clinical policies that serve to make sure that contraceptive services continue during COVID-19. And several participants mentioned policies that ensured that family planning remained a priority. So making sure that it was included in the list of USAID essential services that should be provided. Several participants also mentioned changes in policies related to the provision of emergency contraception during the pandemic, as you can see in the quote here. So in regards to service delivery adaptations that we documented, several mission and implementing partner participants mentioned the creation of guidelines to support the implementation of family planning programs. I think that's probably no surprise. But for example, some missions created risk mitigation plans to guide their work or developed minimum service packages for emergencies. And then several missions and implementing partners implemented or increased mobile services, which I think Nandita also talked about as being a documented adaptation, or they leveraged existing platforms to ensure that the communities received family planning reproductive health services. So in one example, the local government funded tuk-tuks or tricycles to ensure that healthcare workers could transport pills and other commodities into rural communities. And another participant from a USAID mission noted that they employed roving mobile teams to monitor and support the provision of services, which you can see here in the quote. And then several other service delivery adaptations included providing additional stock of commodities to community health workers or to district pharmacies so that they didn't have stockouts because of those supply chain issues that everyone was experiencing. And then assessing stock through phone calls instead of actual visits to health centers, and then integrating family planning commodities into COVID isolation or treatment centers as well. So digital adaptations we saw that in an intro Slido that you all had mentioned. Digital comes top of mind, and Nandita mentioned digital. It was definitely a theme that came up here. I think our other speakers are going to talk about it as well. When I'm talking about digital, we specifically asked participants about implementing or leading virtual trainings or support services for service providers, or implementing telehealth or mHealth approaches, such as providing health services or information virtually or via a mobile phone. And we found that participants in general had digital trainings, and they felt as though digital trainings had several benefits and challenges. The benefits were that it reduced travel costs and it increased accessibility to the content for those who may not have otherwise been able to travel there. But there definitely were issues related to connectivity, and there were challenges that digital approaches, don't really provide the hands-on training that providers may need in order to learn how to insert an IUD, for example, and that there was fewer networking opportunities for service providers when they were solely being trained virtually. There were also telemedicine examples and mHealth examples shared. So aside from these themes that we specifically probed on, there were several additional themes that came up as well. One is one that Nandita also noted, which was the multi-month contraceptive refills. Several countries were already doing that, but they had then documented it into their national policies, and other countries had started doing that due to COVID. And then several participants highlighted that the COVID pandemic was an opportunity to advance self-care, which we also heard about in the initial Slido. Participants shared that while many countries were hesitant to support self-care programming before, that a lot of discussion started happening because of the COVID pandemic regarding policies related to self-care. And then implementing partners and USAID mission staff spoke of adjusting or implementing SBC messages or SBC programs. And several people actually talked more broadly about SBC in that it received more recognition as an approach during the COVID pandemic, and that was a positive for SBC, those working in SBC. And I think I forgot to mention that task sharing was also mentioned in order to ensure that services were reaching those in need. So we asked participants what their top lessons learned were, and they said flexibility and innovation, which I think is a theme that we would all agree with, the importance of having preparedness plans, communication, and advocacy with the ministries of health, ensuring sufficient human resources for the response. So since so many people had shifted from family planning to COVID, there was a sense that there weren't enough people actually working on FP programs to sustain them at the level they had hoped. And then local leadership was also a lesson learned. One of my favorite questions that we asked was, in 3 months, I think, what would you do in the first 3 months of the next global emergency or pandemic? What would you do different, or what would you do the same? And they said, scale back regular activities, ensure staff bandwidth, support the prioritization of family planning programs, coordinate with key stakeholders, and create and disseminate unified guidance. So that wasn't for the COVID pandemic, that's for any future emergency. And then after we collected these findings, we analyzed them, and our study team, of course, had some recommendations. So our recommendations are to put in place systems to ensure that lessons from past emergencies are strategically taken into consideration and used to inform future responses. So this could look like a public synthesized repository of lessons learned, or we could facilitate knowledge exchange activities to support the sharing of lessons learned. And second, put in place policies and procedures to ensure a flexible and nimble response. And then this last one is a real general one, but assess, document, and disseminate the challenges, opportunities, adaptations, lessons learned, and recommendations for all USAID-funded programs. We shouldn't only be doing this for those programs that focused on COVID or family planning, reproductive health. We should be doing this for all of our programs. So that is it, and thank you very much.
Thank you, Anne. Thanks so much for that. You know, I'm a big data person, so I love to work with numbers, but I really have an appreciation for qualitative research methods too, because you just get such a rich perspective that you really can't get from looking at numbers. And so I really appreciate, you know, the opportunity to take kind of reflect retrospectively and get, you know, people's lived experiences from program implementers on the ground, and, you know, learning from that exchange. So thank you for that. Next up, I'd like to introduce Andrea Novella. Andrea is a social media regional manager at Population Services International, and she'll be representing the Research for Scalable Solutions, or R4S project. And she'll be sharing how their projects expanded the use of, surprise, digital technologies during COVID, and how they documented this through an innovative perspective method. So in real time, as they were implementing and adapting, they were also documenting that at the same time. So Andrea, over to you.
Thank you, and good afternoon, everyone. My name is Andrea Novella, and I actually now am heading PSI Social Business Unit Global Consumer-Facing Digital Initiatives, including our Femtech division, VIA. And needless to say, back when COVID started, my workload increased significantly. At the time, I was working with the Latin America team. And today we're going to be talking a little bit about how program innovation and adaptation was crucial, not just in helping us accelerate our digital strategy during COVID, but also as a catapult to help improve on healthcare delivery beyond. And how tracking these adaptations was also a critical part in being able to support that. This adaptation tracking was supported and funded by USAID through Research for Scalable Solutions, which is an implementation science project led by FHI 360 with a consortium of partners including PSI, Save the Children, and the McCares School of Public Health. So just a little background on the R4S process documentation activity. COVID gave us the opportunity to innovate on our healthcare delivery and accelerate our digital healthcare. And in early 2020, family planning programs started rapidly adapting to ensure continuity of services, but not everyone was tracking these adaptations. And so R4S started tracking so that we could be able to understand what was happening and better inform our work across the board. It's understandable, it was a challenge to be tracking all of these changes and innovations at the time, and so systematically documenting did prove to be difficult. And what was interesting about this tool is that it was a really user-friendly tool based on Excel, a very intuitive interface. There was not a lot of change management or having to learn a new solution to be able to implement this. And it helped to track changes and implementations across the high impact practices. So just a quick recap on the HIPs. It is evidence-based family planning practices that reflect what activities most effectively increase voluntary contraceptive use. So we were tracking across service delivery, for example, digital family planning counseling, the enabling environment, which included things like Uber-type delivery apps for at-home delivery, and social and behavioral change, such as our digital family planning self-care information campaigns. And then we also supplemented that with data collection from secondary indicators as well as national COVID-19 policies. And this was updated once a month by our project personnel with central support in reviewing data completeness and quality. And we wanted to track across the board through different geographies, target audiences, so that we could have a broader picture of our adaptations. And so we tracked through 8 different projects that are listed here, as well as 5 countries and 3 different organizations. And this really helped us to make sure that we were looking at a wide breadth of programming to strengthen our knowledge management and also made for better cross-sectoral mobilization. So let's look at one of the examples of these programs that we were tracking, and I'm going to look at the social business unit's work in India as an example. And just a quick overview of what the social business unit is. At PSI, we have a division that is balancing social impact with financial self-reliance through the sale of affordable, high-quality products and services, looking for long-term sustainability. So what we did was launch what we coined the Digital Acceleration Strategy, or the DAS, which we launched in March of 2020 across 10 different countries. And what the Digital Acceleration Strategy did was harmonize existing technologies to help address the need to reduce disruption of family products and service delivery. And what does that look like? There were 3 pillars at the core of the Digital Acceleration Strategy. One was on-demand quality information and increasing access, especially to self-care information on channels that consumers were already on. So think popular social media channels such as Instagram or Facebook. And so in India, we launched a campaign titled The Better Future, which is a social and behavioral change communications campaign. We launched that in June of 2020, reaching almost 6 million people with an average of 1.2 million people per month. The second pillar was connection to care and making sure that we were providing personalized care delivery through these digital platforms, which included e-counseling. And in some countries, we actually shifted our IPC workers and our in-person healthcare workers to cyber educators to start delivering these models online. And then we also started partnering with telemedicine providers so that we could help bridge the gap for service delivery through online channels. And then lastly, we were looking to ensure access, so shifting our models of distribution to deliver products to consumers' front door. And this included working with or partnering with e-pharmacies and e-retailers and Uber-like applications, in some cases even boda-bodas or tuk-tuk drivers, to make sure that we were getting these products to consumers' front door. And you'll notice that these 3 key pillars also align to the high impact practices that we were tracking and discussed earlier. So we've touched a little on how we've innovated in response to COVID-19 and how we've systematically tracked those adaptations. And what did we learn from this experience, and how is this going to help us moving forward? So documenting adaptations systematically and rigorously really helped us at PSI understand, number one, what was done, what were we doing? This really helped us to support in the scale of these adaptations, because we were centralizing everything that we were learning and doing almost in real time and sharing that throughout all of our other markets so that they could be inspired and implement similar programming and what was working and what wasn't. And helped inform what should be continued beyond COVID-19. So definitely digital health delivery is one of the things that we are doubling down on post-COVID, adaptation programming, strengthening our partnerships, and again, the systematic capture of data and insights and dissemination of it. And where are we going to next with this information? We're looking at digitally enabled holistic offerings across health verticals delivered through adaptive management that's informed through data and insights. And one example of a really important learning that we got through all our digital work was the importance of reducing the touch points and delivering a more frictionless journey so that we would increase the impact of our efforts. And our programs are constantly faced with contextual challenges outside of the pandemic. For example, where we face issues such as stockouts. And so having the systems already in place to support rapid and informed delivery and decision-making really helps to strengthen our resiliency and make sure that we are best placed to respond to future health crises. For us, COVID was a crisis, but in some ways it was also a catapult that accelerated all of our digital work, through which we hope to better healthcare delivery in the future and continuously iterating our work through consumer and market-driven insights supported by tools such as R4S is what helps us to deliver on that. So looking ahead, we've taken the learnings that we got across all of our markets globally, and that is where the birth of our Femtech offering came to be. VIA is based on a comprehensive data-enabled social business model that brings together information, products, and services, and delivers it in one place to make sure that we're providing a frictionless journey towards holistic and sexual and reproductive health from menstruation to menopause. It is our belief that VIA will eventually have significant impact, not just in how we are engaging with our consumers, but over time, the nature of how we are approaching healthcare delivery by engaging them in a way that is holistic and supports them across their life cycle. So that's just a little example of one of our digital campaigns in VIA. And if you're interested in learning more, I'd invite you can actually look at the R4S COVID adaptation briefs across the different programs and markets in detail by scanning the QR code over on my left, your right-hand side. And then on the other side, we were also featured in the digital compendium with our digital acceleration strategy. And if you'd like to get more detail on that, you can scan the QR code on my right, your left. Thank you.
Thank you so much, Andrea. That was really actually very refreshing to see that you can document your adaptations in real time without any fancy high-tech solutions. You can use something as simple as an Excel sheet or a Google sheet, and it'll do the job. So thank you for sharing that. Okay, so we have one more presentation. So last but not least, I'd like to introduce Catherine Packer. Catherine Packer is a technical advisor with FHI 360, and she'll be sharing some work that she led for the Knowledge Success Project called Connecting the Dots. And so Connecting the Dots was an interactive experience, digital experience that retrospectively analyzed PMA data on the impact of COVID on family planning use, but it also looked at program adaptations from 3 different countries, and she'll be focusing on those program adaptations.
Thank you so much for coming to the last session, and I'm the last speaker, so thanks for hanging in there. I'm really excited to talk to you today about connecting the dots. So first, I'd like to thank my co-authors. They were from all over the world, and it was really fun to work on. So as Anne talked about, Knowledge Success is a knowledge management project funded by USAID. The goal is to connect family planning and reproductive technical advisors and program managers with information that they can share and apply to improve their programs. So in 2021, we saw a need to figure out how to document impacts of COVID-19 on family planning in Africa and Asia in an easy to relate and understand format. So this is the QR code if you want to check it out, and I'll tell you a little bit more about it. So like Rueda said, we used performance monitoring for action, PMA data, from 7 countries. 4 of the countries had multiple surveys that were nationally or subnationally representative samples of women. And so with those 4 countries that had multiple surveys, you could look at change over time. And so we made this interactive map where you can click on a country. And then when you click on it, the 4 indicators that we looked at are over on the right. So pregnancy desires, contraceptive use, switching to less effective or no method, and COVID-19 impact on contraceptive non-use. So once you click on the country, you see this. You can choose the indicator to look at. And then we mapped the survey data against a backdrop of the COVID situation at that time that the data were collected. So the orange is the cumulative COVID cases. The bar along the bottom shows how restrictive stay-at-home orders were, given that that may restrict women's movement to be able to access services. And then the little blue bars are the data. So in this case, it's showing that pregnancy desires were not really affected due to COVID in this case. So if you click on other indicators, the bars move. So overall, we found less impact on family planning use than we feared. It was sort of a hopeful story. It was interesting. Now, this is population level data, and so it could mask differences of subgroups, but we also did a subgroup analysis and similarly didn't find any big dire impacts. So we sought to try to figure out, well, why could that be? So we synthesized and gathered a lot of information, and as you've heard from this panel so far, I mean, there were some really interesting program adaptations that helped continue service delivery to women. So another part of connecting the dots is 3 case studies where we really documented program adaptations. So we actually worked with the R4S project as well as looked at the IBP map to kind of make sure we didn't have overlap with R4S so we could have different documented experiences, and looked at the IBP map for sort of examples of adaptations that we might want to look into more. So they're from Nepal, Cote d'Ivoire, and Madagascar. And since this panel has a large focus on documentation and knowledge management, I'll just tell you a little bit about what we produced. So we produced a brief for each example that are downloadable from Connecting the Dots. We also did a webinar to share the information. We also have an FP Insight collection, which is another knowledge management, knowledge sharing innovative tool. And then we're here right now sharing with you. So we really looked at trying to describe the program, look at the specific adaptations. We made a similar chart showing the COVID context during when the program adaptations were happening, showing the cumulative cases and stay-at-home orders. And then where possible, we used program or evaluation data to try to see if there was impact. And then we talked about lessons learned for other programs. So I'll briefly tell you about the 3 different adaptations, and then in the spirit of documentation and knowledge sharing, I went back to the co-authors because Connecting the Dots was published in January 2022. We're now almost a year later, so I really wanted to know what was still happening. Were the things that they tried being used in other places? Were they still happening? Like what was learned over the last year? So the first example is from Côte d'Ivoire. We worked with Breakthrough Action and West Africa Breakthrough Action. They were working on a radio campaign about family planning called Confiance Totale, and they changed some of their PSAs related to family planning to fit the COVID context. And I'll play an example of a PSA in a minute. But they did an evaluation which showed positive associations with family planning use and intent to seek services as a result of exposure to the radio campaign. So let's hope this works. This is an example of one of the PSAs from Côte d'Ivoire. Should I? It's well, they are available online. The radio campaign was done in 4 different countries.
Yikes.
There's a little play button at the bottom that just, yes.
Pendant ces temps de coronavirus qu'on appelle Covid-19,
de la planification familiale. Ceci est un message du ministère de la Santé et de l'Hygiène publique.
Thank you. So if you don't speak French, he was basically saying, ooh, we have a little more time at home. We should probably use condoms. We use masks, we should use condoms. So some of them have a nice sense of humor too. So that is one example of how they had already created messages about family planning, and then they're like, oh, COVID is happening. How can we make it relevant for this context?
pendant ces temps de
Okay. That's how it could have happened. Okay, so that radio campaign was done in 4 countries: Burkina Faso, Niger, Togo, Côte d'Ivoire. So in some cases it was done once, right at the beginning of COVID, and in 2 cases it was done a second time. So the bottom line of that experience was that adapting family planning PSAs to incorporate specific COVID context of that place at that time reminded target audiences that family planning is relevant despite being in a pandemic. So the next example is from Madagascar. So we worked with the Access Collaborative, which is run by PATH and JSI. And so basically, just before COVID was starting, Madagascar was just introducing DMPA-SC self-injection. So they had trained providers, and then we're ready to scale up. Now, self-injection is great for COVID because you can get 3 units and have protection for a year. And so they didn't want to mess with that. They thought it was especially relevant to do during COVID. So they developed a remote supervision approach to make sure that providers were being supported. They used phones to check in with them, and basically they were able to reach more providers doing it remotely than in person, and this enabled successful introduction and scale-up of DMPA-SC self-injection. So what's going on now in Madagascar? There's hybrid supervision because though remote training was feasible and effective, there were definitely a lot of providers who preferred in-person. So now, depending on the context, there's remote and in-person supervision. One thing that changed is after normally having like in-person coordination meetings about DMPA-SC, they shifted to more online coordination meetings. And then in 2021, Uganda adopted the checklist developed for how to do remote training and did it there. So the bottom line of this one is that remote supervision is feasible to support DMPA-SC providers. They reached more than in-person, they saved time, they saved resources, but some do prefer in-person supervision. So the last example is from Nepal. So we worked with the Family Planning Association of Nepal, or FPAN, and they had emergency funding that was mobilized, and they were able to quickly reestablish services by doing several different things. So they did community-based distribution of information and short-acting methods. They did digital media, the common thread across everything. They really locked down and looked at their supply chain oversight to make sure there would be, methods in stock. And they really wanted to make sure to take the providers into account. They gave them masks, they gave them incentives to continue to provide services. So this resulted in comparable numbers of clients served as pre-pandemic pretty quickly. Of course, there was a dip at first, and then it quickly raised. So what continued as a result of COVID, they had developed reproductive maternal newborn child health interim guidelines to provide SRH services. And so this is operational now so that the next epidemic, these guidelines are there. So it allows telehealth, it recommends different things that were learned during this time. So they said it was really important to motivate frontline health workers and that involving policymakers to develop emergency response guidelines both facilitates buy-in and accountability. So taking it all together, what lessons can we apply for future crises or pandemics? As we've all said, and I think it's a nice positive message, COVID-19, though it was terrible, also spurred innovations in family planning policies and programs. And documenting and sharing successful adaptations will hopefully enable programs to learn from what worked and what helped the next time something happens. Thank you.
Thank you so much, Catherine. So I worked very closely with Catherine on that piece, and I really appreciated Catherine's framing throughout the whole experience, which was we need to send a message of hope and resilience because it's very obvious that the family planning field stepped up to the challenge of COVID, and we were able to ensure access to family planning use in many areas and for many, many women and families. So that was really, a nice outcome in as much as possible during this difficult time. So we've all heard that the COVID pandemic accelerated innovations, and we do see that that was true from programs that rapidly expanded, the use of digital technologies, so that definitely was front and center in a lot of the adaptations. But we also saw it in the social and behavior change realm, with tapping radio announcements and social media to give people family planning information, and also the use of community health workers for task sharing. What's even more exciting is that some of these innovations have continued even beyond the early stages of the COVID pandemic. So it was obvious that these were useful adaptations that could have staying power. And we hope this panel also demonstrated the importance of documentation and the wide variety of methods that we can use to document program implementation and adaptations. So Nandita shared with us the importance of creating spaces for dialogue between global partners and country implementers, and how that led to a crowdsourced interactive map with different program adaptations. Anne and Catherine both shared documentation approaches from different ways. One was retrospective, and one was in a more prospective way. And finally, Andrea is the one who shared the prospective method. So each of these documentation approaches has their strengths and limitations. I think, it's really innovative to be documenting them in a prospective way as they are happening in real time. And you can do this in a pretty simple way, but at the same time, it does take resources, and I think some projects probably don't have those resources. There's value, though, in doing it from a retrospective way as well. So do we have like a gold standard? I don't think we can come and say there's a gold standard to documentation, but I hope through these experiences we can say that what's really important is that we do document our approaches in whatever way that each of our projects and organizations can do. But I'd love to open it up to you all now, and love to hear from you, what you think about the documentation approaches, what you think about the adaptations that were shared, and if you have any questions for the panelists. So I think we have a microphone back here, so if anybody has any questions, I have one over here.
Hey everyone, great presentations. Thanks so much for being here and for being so enthusiastic, even on the very last session of the week. My name is Kristen Little and I work for PSI, and just wanted to ask, actually this could be for anyone who'd like to answer it, but as we're moving into a world where COVID is kind of exiting at least the emergency phase, I wanted to see if you had any perspectives on the role that adaptation tracking might play in routine programming. Like, we all face challenges, we all have intentions when we go to implement an intervention that don't necessarily go as planned. So I'd just love to hear what you guys think about that.
Great. Thanks for the question. Do we have any takers? Anybody want to start? Anne? Go ahead.
Sure. I just have one thought that comes into mind is that, regular reporting, if we could build in time in those reporting templates to talk about adaptations, both what we're adapting currently and future, like what we have adapted, how are those going? I think that would be quite useful.
Yeah, go ahead, Nandita.
And I'll just add, I think one of the things I don't think I touched on as much was that a lot of the adaptations that we saw, and we saw in the presentations, are coming from countries in Africa or Asia. And what we noticed through our WHO platform is there are actually a lot of lessons learned for Europe and North America. I'm based in Switzerland and Geneva. We are not good at community health work or distribution of any service. And so I think in the future, I think really making sure that this is we have global learning platforms, that we're not just talking about how can we learn in the global south, that terminology's got issues itself, but really how do we, as a global community, take those lessons learned, really advanced lessons from countries that we saw and apply them to other countries in Europe and North America. And I think that was the piece that we really saw impactful in the WHO platform, because we were hearing from our colleagues in Europe, we need to learn from these countries that are doing really remarkable mobile service delivery or community-based distribution. We're just not doing it. So I think that learning across the world is something that we can take for the future. Thanks.
It's a really good point, Nandita. Actually, just over breakfast this morning, we were talking about how innovative, or maybe, Asia has been doing this for so long and using masks, and how the US is so behind and it took us so long, and I don't think we're even still there yet. We're still very uncomfortable wearing masks, but we have a lot to learn from other countries as well, for sure.
I think I would also add that we can probably leverage the momentum from this change management that occurred in tracking the adaptations. And in tools such as R4S, where we have already those systems in place and that tool that has been developed, we can continue to use that moving forward, not just for COVID adaptations, but for our general knowledge management programming and planning.
Great point. Yeah, these tools are not just for one point in time. Yeah.
Yeah, and just one more idea, like we're here at a conference sharing lessons learned. I reached back out to the co-authors to see, well, what is happening? You know, we could have a webinar where we've reached out to other people and share it again. So I think there's creative ways we can continue to share it, but I feel like it probably will kind of stop getting documented, which is hard.
Great. Have a question back there? Go ahead.
Yeah, thank you so much. My question is, to what extent can we use the learning and adaptations for future health emergencies? Because this time it's COVID, maybe another time it will be another pandemic. And we all know that COVID got us unaware. Do we have to be unaware for all the time? So yeah, but the lessons are really great, but their ability to actually prepare us or also to learn or adapt from them in another health emergency is very critical.
Great, yeah. So would anybody like to take that? I got my panelists split in between two big areas here.
I can jump in. So I completely agree. And as a knowledge management professional, you know, I know of a lot of gray literature that's been documented from past emergencies like Ebola and Zika on how we could take those adaptations or lessons learned and apply them to COVID. But I'm not sure how widely read they are or how widely implemented they are. So it is a challenge. I think more knowledge exchange opportunities, and within knowledge success, we've also been talking about potentially documenting those in peer-reviewed manuscripts where I think maybe they will get more eyes or be more widely disseminated or have more weight to them. While I don't think that that's necessarily fair, that may be the case. So making sure to document those lessons learned in peer-reviewed and gray literature, I think, would be important. And just reminding people that they exist. And if they exist on a previous website, you know, making them available on the newest version of the website so they're just really easily accessible.
I also think just these kinds of forums where people can get together and talk makes a big difference. I mean, maybe it's a little bit smaller scale sometimes because we're talking about a smaller group of people, whereas, you know, you publish something in a journal or on a website, you have potentially wider distribution, but I think you can get deeper into the conversation and hopefully then people retain more as well. So I really enjoy having like opportunities to interact with people, and I think people learn a lot in that way as well.
I can say
Catherine?
Yeah, and when I first learned about the IBP map, and I remember thinking, oh, okay, do we have documentation of people using it and sharing it? Like, I think there's a next frontier of questions we could ask, like, did someone download my Madagascar brief and then go use it somewhere, you know? You don't hear about it because it's kind of stops, but I think it would be really interesting to know if people are using these things that we are working so hard to document, and how, and or where they are learning it. And I mean, they must be hearing about it from some different ways.
Mm-hmm. Any other questions? All right, everybody ready for lunch? Okay. Well, if there's no other questions, thank you again for joining us and for sticking with us through the session. Thanks so much.